I think we're going to get going, just 5:30. Want to be cognizant of your time, and just wanted to open it up by saying thank you very much for being here, and good evening to everyone. I want to thank you for being here, as I mentioned, but more so about taking part in this discussion that we're going to have tonight on heart failure. We are incredibly fortunate to have Dr. Andrew Yoon, our Medical Director of Advanced Heart Failure with MemorialCare Heart Vascular Institute at Long Beach Medical Center, and Dr. Kevin Shah, Program Director of Heart Failure Outreach. Both of them are board-certified cardiologists and board-certified in the subspecialty of advanced heart failure. They don't just treat this condition, rather their approach is really to work with patients to live fuller, longer lives through early intervention, treatment, and ongoing support. Their insights tonight, what we're all going to benefit from hearing about, is grounded in their experience, in the latest research, and ongoing commitment to patient care. So whether you're here for yourself or for someone whom you care for, you're in good hands, definitely. We also, just really quick about questions, I kindly ask that we wait until the end. We have dedicated time for Q&A because they want to hear your questions and provide that feedback. So if you just don't mind holding off until the end. And for those of you who are on virtually, just please type in your questions into the comments section. We will definitely read them during that Q&A session so that they too are being answered. So, ladies and gentlemen, please join me in welcoming Dr. Yoon and Dr. Shah.
Thank you, Rose, for that very warm welcome. My name is Andrew Yoon, and I'm a medical director, as Rose said, at the Long Beach Medical Center for Advanced Heart Failure. And so our talk's going to be broken down into 7 sections. I'm going to be talking about the first 3, epidemiology, clinical presentation, and diagnosis of heart failure. And Kevin's going to come on later to talk about prevention, treatments, research, and future directions. So, epidemiology. There are over 7 million patients diagnosed with heart failure in the United States of America. And that number is growing. It's getting higher and higher with every single year. And these are patients who are diagnosed with heart failure, which means that there are even more people out there who are not diagnosed as of yet. And it causes over 85,000 deaths per year. And as you're probably aware, there's this really cool, fantastic treatment for people who are dying of heart failure called heart transplant. But in 2024, there were only 4,500 heart transplants performed in the United States of America. So the blue line represents the number of heart transplants, Blue line represents the number of heart transplants done in America every year, and it's going up. The orange line represents the number of people diagnosed with heart failure in America every year, and it's going up. But the orange line represents millions of people on this orange axis. The blue line represents thousands of people. So basically what I'm saying is that if 85,000 people are dying of heart failure every year, and only 4,000 people are actually getting heart transplants, that means about 95% of people who are dying of heart failure every year are never going to get a heart transplant. Heart transplants only for 5% of the people. So there's a lot of people who can't get heart transplants are going to die waiting for a heart transplant, unfortunately. So we're trying to catch people with heart failure before they even get to that stage to do whatever we can to prolong their lives and buy them as much quality of life as possible. So despite current therapies and disease management approaches, the rate of heart failure hospitalizations remain high. More than 1.1 million heart failure hospitalizations occur in this country annually. It's the #1 cause of hospital readmissions. More than 25% of heart failure patients are readmitted to the hospital within 1 month. And more than 50% of them are readmitted to the hospital at 6 months. And it's an incredibly expensive healthcare problem. The average annual cost for heart failure hospitalizations in this country is over $36 billion. And each heart failure hospitalization costs on average about $17,000. So this is a very, very expensive disease with a very, very high rate of readmissions to the hospital. Now, just a word on gender. There's this very fascinating town in Massachusetts called Framingham, located right outside of Boston. And in Framingham, they've been studying the population ever since 1948. And we've learned so much from Framingham. What they do in this town is they follow everybody in the town, and they've followed them for over 3 generations. And they're trying to figure out what are the causes of heart disease? What are the things that these people are doing that lead to increased amount of heart disease? And we all know that high blood pressure causes heart disease. Makes sense. And we all know that cigarette smoking causes heart disease. Makes sense too. But we know that because of the Framingham study, following all of these patients over multiple generations since 1948. And what we also know from studying these people from Framingham is that patients who are diagnosed with heart failure don't necessarily do well over time, and women do worse than men. So on the right side, we have these things called Kaplan-Meier curves, which shows survival over time. On the top right is women, on the bottom right is men. And on the top right, the dark black line shows survival in the 1950s, showing that at 10 years' time, survival for women was about 10% at 10 years for women diagnosed with heart failure. For men, survival at 10 years in the 1950s was about 20%. And if you go to the top light colored line, that's the 1990s, you can see that survival over time for heart failure has improved. For women at 10 years after the time of their heart failure diagnosis, survival is about 20%, but for men, survival is over 30%. And we know this about women with heart disease in general. They're often underdiagnosed, undertreated, and they have higher mortality. And this is also true for women with heart failure. So what exactly is heart failure? Heart failure is a condition where the heart doesn't pump blood to the rest of your body as well as it should, which can make you feel tired, short of breath, or swollen in your legs and feet. It doesn't mean that your heart has stopped working, but it does mean that it needs help. And some people manage heart failure with medications, lifestyle changes, like eating healthier and staying active, and sometimes more advanced treatments. And Kevin's going to get into this in the second part of this presentation. But the goal is to keep symptoms in check and help the heart pump as best as possible. And so there are 2 main types of heart failure. One's called heart failure with reduced ejection fraction, and the other is called heart failure with preserved ejection fraction. And the best illustration I can think of to describe these 2 is to imagine a balloon. Now, a normal ejection fraction is greater than 55%. And what ejection fraction means is how much blood in the heart is being pushed out of the heart to the rest of the body with each heartbeat. And you might think, well, 55% seems like a low number. Shouldn't it be 100%? But the reality is when the heart pumps, it doesn't pump and collapse completely, pumping out all of the blood with each heartbeat. When it finishes pumping, there's still blood left over within the heart. So 55% or higher is considered a normal pumping function for the heart. And for heart failure with reduced ejection fraction, you can think of the heart as a very limp, very big, very stretched out balloon with no elasticity whatsoever. So when you fill it with air and you're trying to squeeze out the air, it's having a tough time of squeezing out all of the air within that balloon. And the heart failure with reduced ejection fraction is analogous to that. And I'm going to show you a video on the next slide to show you exactly what that looks like. Heart failure with preserved ejection fraction is a little different. For heart failure with preserved ejection fraction, you can think of a balloon that's extremely stiff. The kind of balloon where you're huffing and puffing and trying your best to fill it with air, and your cheeks are getting tired, your muscles are getting sore, your lips are getting, it's tough to fill it up with air. It squeezes just fine. But filling that balloon with air takes a lot of energy and effort. That's heart failure with preserved ejection fraction. So great, it's working. Heart failure with reduced ejection fraction. On the left here, you see a normal heart. And on the right is a heart failure with a reduced ejection fraction. Now, cardiologists sometimes were terrible people. I'm going to take you through this. As you know, this is the heart has 4 chambers. This chamber on the top, this is the left ventricle. The ventricle is the bottom chamber of the heart. So yes, I know that in this video, the bottom chamber of the heart is on the top. This is the right ventricle, which is on your left. These are the two atria, which are the top chambers of the heart. But for whatever reason, cardiologists like to put, when we look at these pictures, we like to put them on the bottom. So this is the left atrium, and this is the right atrium. We like to make it super complicated. So this is the left ventricle, which is your top right chamber, but really the heart's bottom left chamber. So these are the walls of the left ventricle, and this is the main pumping chamber of the heart, which pumps blood to the rest of the body. And as you can see, it's squeezing pretty well, very strongly, very normally. And when it finishes squeezing, there's still blood, the black space, that's still left over in the left ventricle when it finishes squeezing. So that's why we say ejection fraction 55% or higher is normal. Now compared to this heart here on the right, this is someone with congestive heart failure with reduced ejection fraction. The left ventricle is much bigger than this normal one on the left, and the left ventricle is barely squeezing. This is someone with an ejection fraction of about 20%, which is someone who has severely reduced ejection fraction. This is heart failure with reduced ejection fraction, or as we like to say quickly, HFrEF. And so what do patients with heart failure present with? The main symptom is shortness of breath. On the left, you have someone with a normal chest x-ray, and on the right is someone with congestive heart failure. You can see, looking at the chest x-ray, this shadow here is the heart, and the horizontal dimensions of this heart, it's about 1/3 the total distance of the chest cavity. This is a normal heart size. On the right is someone with congestive heart failure, and you can see that the horizontal dimension of this shadow here is much bigger than on the left. This left ventricle, this heart on the right is about half the distance across the total chest cavity. So we know, just looking at the chest x-ray, that this is a very large heart. And look at the lungs. On the left with these normal lungs, you see a lot of black spaces. Black space is good, that means it's filled with air. On the right, you have a lot of white fuzziness. This white fuzziness represents fluid or blood that's backed up, that's static, congested within the lungs. As you can imagine, this person with congestive heart failure, even though he's taking very deep breaths, the ability of oxygen to enter into these lungs to be absorbed is diminished. So even though he's taking deep breaths, he's feeling very short of breath. And that's a very common sign for people with congestive heart failure, is to feel short of breath. And we can measure the shortness of breath using what we call the New York Heart Association classification scheme. And it's in four classes. Class 1, which represents mild, all the way to class 4, which is severe. And class 1, New York Heart Association classification scheme, is someone who is diagnosed with heart failure but has no symptoms whatsoever. They're able to walk, do all their activities of daily living, no symptoms whatsoever. And a lot of people who have heart failure but have not been diagnosed yet, but their heart has started the process of getting big and getting weak, are in class 1. Class 2 is people who have shortness of breath only with heavy exertion. So for example, lifting heavy weights or walking up a hill, you feel short of breath, but doing other activities of daily living, you have no problems whatsoever. That's New York Heart Association class 2. Class 3 is moderate shortness of breath, meaning shortness of breath with doing activities like walking across a room or dressing or taking a shower. If you're having shortness of breath doing these kinds of activities, then we call that class 3 shortness of breath in the New York Heart Association scheme. And class 4 is people who are severely short of breath. These are people who get short of breath even just sitting there, trying to sleep, trying to breathe, or even taking 2 or 3 steps. That's severe shortness of breath, or class 4. And the shortness of breath often manifests especially at night in a phenomenon we call orthopnea. People with congestive heart failure frequently feel that when they're lying down at night to sleep, they get more short of breath and they start coughing more. That's a very classic symptom for congestive heart failure. There's also another very common sign for people with congestive heart failure called edema. Not everyone with heart failure has edema, but most people do. And it's either edema in the legs or in the abdomen. Frequently the legs, because gravity tends to pull the excess water in your body down to your feet. We call it pitting edema because when you push it with your finger and you remove your finger, you can often see a pit there, indentation or impression of your finger that just persists. Now, there are many, many causes of edema that don't have to do with heart failure. For example, certain thyroid diseases can cause edema, pardon me. Liver disease, kidney disease can cause edema. So can certain medications. Lymphatic disorders can cause edema. Lymphatic is kind of this alternate circulatory system in your body that drains fluid from excess fluid from your body from certain areas of your body. And if you have disorders of the lymphatic circulatory system, you can get edema, as well as severe malnutrition. But it's pretty easy to go through this list and knock them off as causes of edema to figure out if this edema is caused by heart failure or from something else. Cardiologists love looking at people's necks because when there's too much water in the body, one of the phenomena that we see is called jugular venous distension, which just means distended jugular veins. So this is what a distended jugular vein looks like. And it's common to have this when you're lying down flat on your back, but when you're sitting up and you still see a distended jugular vein, that's a very, very common sign for someone who has congestive heart failure. Now, not everyone with distended jugular veins has congestive heart failure. There are other causes for distended jugular veins, and one of the things you may have noticed is that people who perform for a living, professional singers, will often have distended jugular veins as well, and it's a phenomenon called singer's neck. Doesn't mean they have congestive heart failure, because they don't. Just means they sing a heck of a lot. But if you're not a professional singer, and you're short of breath, and you have distended neck veins, it might mean you have congestive heart failure. Bendopnea, it's a little bit rare, but it's also a shortness of breath phenomenon that a lot of people with congestive heart failure experience. And that's the phenomenon of bending over to pick up things, and just bending over, that act makes you short of breath. That's also a common sign or symptom. Not as common as the others, but it's also a sign of congestive heart failure. And this is a very famous diagram in the congestive heart failure literature showing that your symptoms are not stably chronic over time when you are diagnosed with congestive heart failure, but rather they change. And so let me go over this diagram with you. The x-axis is time and the y-axis is how you feel, quality of life. So when you're first diagnosed with congestive heart failure, you feel like something bad has happened. You go to the hospital. We see you, we take care of you, we treat you, tune you up, start you on medications, do whatever we can to reverse the congestive heart failure, and you feel a lot better. Your symptoms get better, almost back to normal. And then there's a long, stable period of time where you feel great. This period of time can be anywhere from 5 to 10 years, some of my patients even longer. But it can be a very long time if you're following the diet, taking your medications, seeing your doctor, doing all the things that you're supposed to do. But as your heart gradually, slowly gets weaker, slowly gets bigger, you might have to come back to the hospital again. So we tune you up, get you a little bit better, but then a shorter period of time happens before you have to come back to the hospital again. So we treat you, tune you up, get you better again, but you're never quite as good as you were before, and there's an increasing frequency of rehospitalizations until you get to the point where you're just feeling terrible no matter what we do. You're feeling short of breath, even with a short, class 4 New York Heart Association symptoms, feeling short of breath, even just sitting there talking. And that's a situation where we have to consider things like heart transplant, if it's available and if you're a good candidate, things like that. So we want to do everything we can to prevent this, extend this period of time for as long as possible, to buy you as much life, quality of life as possible as well. So what are causes of heart failure? There are a lot of causes of heart failure. And I'm going to go through some of these, not all of these, but this being America, one of the most common causes of heart failure is coronary artery disease. And the other common cause of heart failure is untreated hypertension. So how do we diagnose congestive heart failure? Well, number one, of course, is your symptoms. The doctor is going to talk to you, and you talk to us. You let us know how you're feeling, what you're experiencing, if you're having shortness of breath or those other things that we talked about. We're going to examine you, look for things like the neck vein. We're going to spend a lot of time looking at your neck, listening to your lungs, listening to your heart. And of course, you tell us your history. In some families, congestive heart failure is an inherited disease. It's in the DNA. Some of my patients tell me my grandfather had heart failure, my uncle has heart failure, my brother has heart failure, I have heart failure. And so we know that in certain families, it's in the DNA. We'll get an EKG, an echocardiogram like you saw. There are lab tests. There's one very important lab test called BNP, or brain natriuretic peptide. As I told you, cardiologists are terrible people. It's called brain natriuretic peptide, but it actually measures kind of heart function. I don't know why they called it that way, but in general, BNP is supposed to be low. But when your heart is under a lot of pressure, under a lot of stress, your BNP levels go quite high. And so when we see that on your blood test, then we have a very high suspicion of your heart, whether it's in failure, and how bad that heart failure is. And we also want to look for a coronary artery disease. And there are a lot of ways we can detect coronary artery disease, whether it's a stress test, cardiac CT scans, or cardiac catheterization. So let's talk about coronary artery disease. On the left is a normal heart, on the right is a dilated heart. And the heart, besides pumping blood, in order to work effectively, it needs to receive good blood. And the way the heart muscle receives good blood is through these arteries on the surface, outside surface of the heart, called the coronary arteries. So on this diagram by these arteries shown on the outside surface of the heart. Now, if the arteries are nice, wide, and open, the heart muscle can pump very well and strong. But if the arteries have blockages in them, you can imagine then the muscle is not going to receive very good blood flow through the coronary arteries, and the heart is going to respond to that, the muscle is going to respond to that by getting bigger and weaker. And the gold standard way of looking for coronary artery disease is to do a test called a cardiac catheterization, also known as a coronary angiogram. You've probably seen this on TV, where we use a needle hole in the groin, and using a catheter, which is just a fancy word for a long, thin, hollow plastic tube, we thread it through the arteries of the body, going all the way up inside the heart. And in this side of the tube, we inject contrast dye. So when the contrast dye comes out inside the heart, we can take X-ray pictures of the heart from multiple angles and see the arteries of the heart. So in this video in the middle, you can see that this is the catheter here. The tip of the catheter is injecting contrast dye into these arteries, so you can see these coronary arteries that are lining the outside surface of the heart. And what you might not know, looking at this, is that there's a big artery here that's missing. It's kind of blocked right there. For people looking on this side, there's a big artery missing right here. And when we go to the next video, I want you to pay attention to this portion right here. It's the same. So in this particular patient, my partner, what he did was, using a variety of wires and balloons and stents, was able to open up that blocked artery to restore blood flow to that big artery that you see now filling up with contrast dye. This is one of the reasons why when people are complaining of chest pain, and it's quite intense pressure, we tell them to go to the emergency room right away. Many cardiologists, we've all had the experience of patients who are experiencing severe chest pain who say, maybe it'll get better, I'll sit it out, maybe it'll go away, maybe it's just gastritis or something like that. Wait 3 or 4 days. When they finally get to the hospital ER, it turns out that they've had a heart attack. And you can imagine, in that hypothetical case, if we opened up the artery, even though you make the artery nice, big, and beautifully wide open, that heart tissue in this area here that hasn't been seeing any blood for 3 or 4 days, even though you opened up the artery, it's going to be scarred over. It's not going to pump well, even though you restored the blood flow. And the heart's going to get bigger and weaker because of the delay in care. Whereas if you're having, say, a second hypothetical patient who's having severe chest pain, goes to the hospital right away, within a couple of hours, gets this test done, they see the blockage, they open up the artery. By opening up the artery quickly, you can see that the heart would respond very well to that reestablishment of blood flow, and it's going to pump just well, and the ejection fraction is going to be fine. The delay in care will cause a decrease in the ejection fraction. In cardiology, we like to say time is myocardium, just a fancy way of saying time. The quicker the time you spend to open up the artery, the less heart muscle you're going to lose. Just another quick word. It can be very tricky sometimes for women. As many of you know, women sometimes when they have a heart attack for chest pain, they don't necessarily present with chest pain. I recall one of my patients who told me she felt like she was just having a terrible flu. She just had fatigue, she was just feeling run down. She just decided to wait it out. She was hoping she'd get better after a couple of days. When she finally went to the hospital, they said, "Oh my gosh, you're having a heart attack." Went and opened up her artery. Unfortunately, the damage had been done, so now she had heart failure. So women, unfortunately, have to have a higher index of suspicion. They tend to get underdiagnosed because their symptoms are not always classic. Hypertension and obesity are also very important. They can also lead to congestive heart failure. There's something we call the HFpEF score, or heart failure preserved ejection fraction score. And it's just kind of a way for us to kind of assess whether someone might have heart failure or not. And if you look at this score, you can see that if you are obese, you get 2 points. If you have high blood pressure, meaning you're on 2 or more blood pressure medications, you get 1 point. If you have atrial fibrillation, which is a very common arrhythmia as people get older, you get 3 points. If you're elderly above the age of 60, you get 1 point. And if you have pulmonary hypertension or if you have elevated filling pressure, these are measurements that we can get from an echocardiogram. You get 1 point each. Now, I don't want you calculating your HFpEF score. No. But what I'm saying is, we use a score for people presenting to us with symptoms of shortness of breath. This is for screening people who have shortness of breath. And so if you have a score of 2 or less, we know you don't have HFpEF. Even though you're feeling short of breath, it's probably something else, asthma, I don't know what. If you have a score of 5 or higher and you're having symptoms of shortness of breath, then you have a high likelihood, probability that you have heart failure, preserved ejection fraction. If you have a score between 2 and 5, it's indeterminate. We have to do more testing to try to figure out if your shortness of breath is related to heart failure or not. Just a couple words of some of the other causes of heart failure. Like I said, sometimes it's inherited. Alcohol abuse, drug abuse definitely can cause congestive heart failure. As we know from the pandemic, virus infections can definitely cause heart failure in a phenomenon called myocarditis. There's a very rare condition called peripartum cardiomyopathy, where women sometimes at the time of delivery, when they're in labor, can develop heart failure, usually reversible. Pretty rare. We only see a couple of cases that per year at Long Beach Memorial Hospital. Let me just say a couple words about what's called broken heart syndrome. I'm sure you're all aware that sometimes in the news you hear about people dying of something called a broken heart syndrome. And it's a well-known phenomenon where in cases of great emotional stress, people sometimes die suddenly of congestive heart failure. It's a picture of the Bushes. Barbara, she passed away first, and then her husband followed her just several months later. And we're not surprised when we hear about these kinds of situations. And it was first described actually by Japanese doctors. And they call it takotsubo cardiomyopathy. If you eat sushi, you know that tako means octopus. Tsubo means basket or trap. And the reason why they call it takotsubo cardiomyopathy is because they felt that when they saw hearts in the situation, it looked just like an octopus trap. Here's an octopus trap on the bottom right. Japanese fishermen would put a little bit of bait inside the basket, lower it into the ocean. Octopus would go in, then they'd lift it right up. So in this picture, you see an angiogram of the left ventricle, the main pumping chamber of the heart, filled with contrast. When it's filled with contrast, and then after it squeezes, this is what it looks like, which is a very unusual shape. They thought that this shape looked like an octopus trap because a normal heart should squeeze evenly so that the left ventricle would look very narrow at the end of the squeeze. But here on the right, you could see that this portion and this portion of the heart squeezed quite well, but this portion of the heart didn't move at all. This is luckily for most people who go through this phenomenon of great emotional stress or some type of stress, this usually resolves. This usually gets better over a couple of weeks or even a couple of months, but not always. Sometimes, as the previous slide showed, sometimes people do die from this condition. Just shows you how strong the power of the mind can be on your health. And so, in addition to all these other diagnostic tests, there are other tests that we can do to try to tease out what's causing your heart failure if it's not clearly discernible. So for example, we have other imaging tests like cardiac MRI. There are additional blood and urine tests we can do. Cardiac biopsy, in some rare situations, we actually have to take a teeny tiny piece of the heart to study it under the microscope to see what is causing this heart failure in certain situations. And again, there's genetic testing. There are a variety of DNA testing now because we're understanding more and more that a lot of these diseases, heart failure syndromes, do run in families. And so some families just want to know. They want to know in terms of their children, their descendants, what are the potential possibilities that it's inherited and risks to future generations. And I just thought this cartoon would be a cute segue to introducing my partner, Dr. Kevin Shah. And the cartoon says, it's a simple stress test. Do your blood work, send it to the lab, and never get back to you with the results. As I said, cardiologists can be very terrible people.
Dr. Yoon, that was fantastic. I feel like I'm back in medical school. That was a really good review. So thanks everyone for coming today. I'm going to be covering the second half, which is really how do we prevent this disease? How do we treat this disease when we have it? And then what are really all the local options that we have for advanced interventions, which is actually quite a lot. This is probably the most exciting time to be practicing in this space. I'm about 6 years out from training now, and I spent the last 5 years out of state at an LVAD transplant program. And so coming back close to home and then covering all the options that we have now, even in the last 5 years, so much has changed in a really positive way. We're going to start with prevention. Like anything in heart disease, we really want to prevent it before it actually occurs. And we do have some good data about how we can actually prevent both heart disease and everything Dr. Yoon covered, which is heart failure. We have good data that diets can actually make a big impact. The two that have been studied the most are the DASH diet and the Mediterranean diet. They have a lot of similarities. Both diets really rely upon your plates being full of fruits and vegetables, and so I appreciate the spread tonight and that it did have a good amount of fruits and vegetables. The DASH diet is an acronym. It's a diet associated with trying to stop hypertension. And we're going to talk about hypertension and high blood pressure, how if we can treat that, we can actually reduce the risk of developing heart failure in the future. Beyond just these two diets, the Mediterranean diet and the DASH diet, regular aerobic exercise has been shown and studied that this can actually prevent the development of both heart disease and heart failure. There are general guidance recommendations, 150 minutes per week of intense aerobic exercise. What I tell all my patients is that as much as you can do in terms of either walking, pushing your heartbeat, really when you're exercising, ideally pushing yourself a little bit where you're feeling a little short of breath, that's what we want to see, and that type of exercise really pays dividends long term when we're compounding this risk and trying to lower it over time. So going on with prevention, a lot of the stuff that we see in general cardiology practice and in your primary care clinic offices, these are things like your blood pressure, these are things like your cholesterol. Knowing these numbers, knowing what your LDL, knowing what your cholesterol is, knowing what your blood pressure is, a lot of these, as you probably know, can increase over time and you may not have any symptoms. So if you're not having routine screening, if you're not having your cholesterol checked regularly, if you're not having your blood pressure checked regularly, and I appreciate we check blood pressures tonight as well for individuals, you won't know oftentimes that it's elevated because you may not have any symptoms from it. And so for a lot of folks, making sure you're getting your regular checkups, knowing your numbers, blood pressure, cholesterol over time, and managing these risks is going to have a downstream consequence of avoiding or at least lowering the risk of developing heart failure in the future. Maintaining a healthy weight is an important part. We're going to talk a little bit tonight. There's a lot more attention being put on obesity, really as its own disease. Not just a risk factor for disease, but a disease itself. And we're going to talk about some of the drugs that really have the best data in the management of heart failure in patients with obesity. Don't smoke. That goes without saying. If you do smoke, try to quit. If you need help trying to quit, let anyone know in medical practice. We want to help people. We want to help people who do smoke try to stop smoking, and there's a variety of ways to do that. Alcohol is an interesting one in that there was a time when I think it did receive some attention as potentially helpful for the heart disease, potentially helpful in terms of phenols and what it could do to the heart. More and more science is showing that, number one, nutrition science is really tough, but more and more we're seeing that it's probably not as beneficial as people think it was. And so for patients that don't drink, I encourage them not to drink. And then for those that do drink, everything in moderation. And then I mentioned sleep-disordered breathing. So this is a broad spectrum of diseases, but you've probably heard of sleep apnea. This is when, while you're sleeping, you may have episodes where you're not completely breathing. And a lot of times we find out about this, not necessarily from patients, but it's always great when their husband or wife is in the room as well, because we can ask, hey, does your wife does it ever look like she's not breathing while she's sleeping? And many times it's very obvious to a partner that, yeah, he has these episodes or she has these episodes where he looks like he's not breathing that well, or she looks like she's gasping for air. That's probably a clue for potential sleep apnea. And when we see that, managing that in its own, and that's a separate subspecialty, usually within pulmonary medicine, managing that sleep apnea can actually lower your downstream risk of developing heart failure. And so on the medical therapy side, this is an area that's really exploded, I would say, in the last 5 to 10 years. We used to have a small selection of medications. Now, frankly, from my perspective, we almost have too many medications. Getting patients on all the medications that we can use to help them manage their heart failure is probably one of the most challenging things when it comes to the tolerance of all these medications and the cost and access to these medications. Dr. Yoon already mentioned it earlier. Broadly speaking, heart failure in general, we subdivide into reduced or preserved ejection fraction. There's also a category that's kind of in the middle, but that's one that's a little bit less well studied, so we'll keep it simple today with reduced and preserved. We have a long list of medications for both categories that can really help manage the condition. And so this is a slide for heart failure with reduced ejection fraction. This is the subtype where the heart doesn't pump as well. And it's titled the 4 pillars because these 4 classes of medication, each one in isolation, has been shown to help extend survival and improve heart function and improve quality of life in people that are on the medications. So, and we'll go through what the details of the medications are, but you'll see we're trying really hard to get our patients on these medications because they actually all extend life. The general categories are on the far left. This is your RAS inhibitors. So these are medicines like sacubitril, valsartan, or Entresto, medications like lisinopril, losartan, enalapril, captopril. You may be on these medications for other reasons, things like blood pressure, but they're really cornerstone medications for heart failure management. Beta blockers, so these are medications that rest the heart and slow the heart down. Specifically, we're using medicines like carvedilol, long-acting metoprolol, and a medicine called bisoprolol. These have all been studied, again, in rigorous trials to show they can actually prolong survival. Third, we have a group of medications, either spironolactone or eplerenone, technically water pills, but they actually help the heart get stronger and help people live longer. And then last, the more recent development, the last 5 to 7 years or so, are the SGLT2 inhibitors. These are the medications, the Farxigas and Jardiances of the world, and we'll go into them a little bit more, but they have very compelling data to help the heart. So one of the sort of cornerstones of heart failure management, particularly reduced ejection fraction heart failure, is, as I mentioned, when a new diagnosis is made, on the top, hopefully you can appreciate step 1, which is we're trying to get patients ideally on all 4 of these classes of medications. And then step 2, most of these medications require dose titrations, meaning there's target doses that were studied in clinical trials, and we do the best that we can to up-titrate those doses because those are the doses that were shown to really provide significant benefit to patients. And this can take a little bit of work. This is a lot of phone calls. This is collaboration with our patients. It's a lot of blood checks to see how your kidneys are doing. And a lot of patients, we're monitoring things like their blood pressure and their heart rate. And the reason we care so much is on the bottom of the slide, on my left and your right, there's something called all-cause mortality, which is dying from anything, and the number needed to treat is 3.9, which is basically almost 4 individuals. If we're able to get them on all of these medications, we can extend average survival by 7 to 11 years. So that means we're trying really hard to get patients on these medications because the absence of the medications means you probably won't do well. And the presence and tolerance of the medications means we can really extend your life where you're not as concerned about this diagnosis. You're still managing it, but you can really see an impact on how you do long term. I mentioned the Farxigas and Jardiances. This is the dapagliflozin and empagliflozin are the 2 generic names. These medications have made a real splash, I'd say, in cardiovascular disease and in heart failure management. They technically work on the kidneys. They cause you to urinate and urinate more sugar, but they've been studied again and again in heart disease prevention trials. They've been studied in heart failure trials, and they've been studied in chronic kidney disease trials, which on your right, you can see the medication class is kind of at the middle of all 3 of these. It's technically originally a diabetes medicine. Now we have a wealth of data in the heart disease space, and we're developing data in the kidney disease space. So a lot of our patients, we're trying to get on these medications if they have these indications because we know it can be pretty powerful for their heart. I mentioned heart failure with reduced ejection fraction has a long list of medications that can really help people do well long term. Heart failure with preserved ejection fraction, it's had challenges in terms of how it's been categorized, how it's been studied, and then really what treatments can really help patients do better. The ones that we have the most data for are technically all water pills. So water pills mean pills that help you urinate, right? And on the top of the screen are your loop diuretics. These are your Lasix or furosemide, maybe a bumetanide, maybe a torsemide. All of these pills make you pee more. And the idea is you're treating the congestion, that fluid buildup, urinate it out, people tend to feel better. We have other medicines, the spironolactones, the Farxigas, the Jardiances, same thing. They help you pee more, people tend to feel better. Mixed data in terms of how well they help people survive long term, but they certainly help from a congestion perspective. And then I alluded to this earlier, this concept of treating obesity as its own disease. This is probably one of the more exciting spaces in cardiometabolic health right now, which is, you've probably heard of these GLP-1 agonists. These are medications, most of them are subcutaneous injections. They're starting to develop oral agents as well. These are the tirzepatides, the semaglutides, or Mounjaros, Wegovy's, Ozempics of the world. Similar issue with the last class of medications, the SGLT2 inhibitors. These were originally studied for diabetes, and then they found that if you use the right dose, people lose a lot of weight, and so they're being used very much as a weight loss medication. And importantly, cardiologists like to use medicines that work in other diseases and say, let's study it in the heart. And now we have a couple of large trials for the heart failure with preserved ejection fraction in people who are obese, meaning their BMI is greater than 30. If they were prescribed semaglutide, so this is Ozempic or Wegovy, if they were randomized to that versus a placebo, sure enough, we're looking at 2 figures here on the top. This is how they feel, so something called a KCCQ-9 score. People feel better when they lose weight, not terribly surprising, but also the weight loss is pretty significant. People in this trial on average lost around 12 kilograms if they were on the drug in terms of weight loss. And so it's this basic idea of how much is obesity really driving this form of heart failure? And there's a pretty tight relationship between the two. I had a patient in the clinic just last week ask me, do I have this heart failure with preserved ejection fraction just because I'm fat? And that's probably a simple way of simplifying the problem, but there's a tight relationship between obesity and developing this kind of stiffer heart that holds on to fluid. The ejection fraction doesn't drop, but as a result, people can start to back up with fluid. The other one that's been studied, and this is a really exciting paper that was also just published in a large randomized trial. This is tirzepatide. This is another one of the GLP-1 agonists. This was studied similarly in patients with obesity, patients with heart failure with preserved ejection fraction. And this actually showed a signal that it may potentially help people live longer and avoid being in the hospital. So now we're getting to the stage of if we have obesity and we have heart failure with preserved ejection fraction, there's a really strong and compelling case to try to help people lose weight with these medications, which are reasonably well tolerated other than the side effects of nausea. A lot of people do have nausea on them, but helping them lose weight may actually help them from a heart perspective long-term as well. And so this is probably one of the more exciting areas right now in our space. So beyond medicines, there's so many cool devices and tools that we have in our armamentarium right now to help our patients. Each of these could be its own separate lecture, its own separate 1 hour of putting things in the heart, measuring things in the heart, shunting blood in the heart. I'll highlight just a few of them. On the top left, we have monitors. We've been using these for a while. It's called a PA sensor. The trade name's CardioMEMS. These are little sensors. They're about the size of a paper clip. We put them inside the pulmonary artery. We measure your pressures, which is a marker of how much fluid you're retaining. And instead of having you come in, weigh yourself, come to the clinic, from home, we can see what your pressures are, and we'll call you and say, hey, your pressures are going up. It might be time to increase your furosemide. It may be time to increase your Bumex. Dr. Yoon and I both have a handful of patients that have one of these monitors. The right patient, very, very useful. Beyond putting pressure monitors, we'll talk a little bit in clinical trials. We have tools where we put tiny holes. Cardiologists like to plug holes in the heart, and then in some patients, we like to create holes in the heart if we think it's actually going to help them. There's surgical options. There's certain pacemakers that may be beneficial. Moving on to the right, we use things like pacemakers that have different functions that can help the heart. We have options to fix leaky valves in patients with weak hearts, and there's a long list of other things. So beyond just those medications, there's a long list of tools that for the right patient, they can really help them. And part of the reason for today's talk is to help you understand that there's a long list of options for you, and just making sure you know that there's more than just medications. There's things we can really do to help. I'm gonna briefly mention this group of conditions, and Dr. Yoon mentioned some of these before too, the cardiomyopathies. This is sort of a subgroup that still falls under the umbrella of heart failure. These are specific heart muscle conditions where there's something going wrong with the heart muscle itself. And these are three distinct conditions that, again, could have probably 3 separate hours dedicated to them. On the left is hypertrophic cardiomyopathy. That's when your heart muscle thickens without an explanation for why it thickens, so it's a genetic predisposition. This class of heart disease is something we're seeing more and more, and beyond the traditional treatments, there's a whole new class of medications that we can potentially use that actually target relaxing a thickened heart muscle, and this is a class that's getting a lot of attention, and we're using it now. These are the mavacamtins and the afiacamtins of the world. These medications can really help hearts that are too thick. That's a genetic cause. In the middle is something called amyloidosis. Amyloidosis is a condition in which the body develops too much protein. Also a condition we're diagnosing much more frequently now than we did when I was in medical school. We rarely made this diagnosis because we had 0 treatments. So why make a diagnosis and tell someone, I'm sorry, you have a really tough condition? Now we have a wealth of treatment options, both. There's a few different subtypes, one where the bone marrow makes too many proteins, one where the liver makes too many proteins. Both of them have long lists of treatments, but these proteins, they can pick on the heart. When they pick on the heart starts to fail. And then on the right is something called cardiac sarcoidosis. Not terribly common, but it's a condition where it's an autoimmune condition in which the heart can really light up in patches, and it can cause rhythm problems, it can cause heart failure, and the treatment for this is immunosuppression. So you really want to be working with a cardiologist that's comfortable managing things like steroids and methotrexate, because it's a very unique treatment pathway that's not like the other forms of heart failure. This is probably the slide that I would highlight that I think encapsulates this whole spectrum of both disease and then also what can we actually do about treatment. So starting at stage A, these are people that are just high risk. They don't have any symptoms, but maybe they have high blood pressure, maybe they have obesity, maybe they have diabetes. Our goal, all of us within cardiology, is to try to keep as many people there as possible, right? To manage all those risk factors and not bump up to stage B, which is when we start to see abnormalities on the echocardiogram. We start to see abnormalities when we do a cardiac catheterization. Now you've developed some actual objective findings. Stage B to stage C, that's when someone has heart abnormalities and now they have symptoms. And Dr. Yoon covered those really nicely. I get short of breath when I bend over. I get short of breath when I lay down. I have this weird chest pain. Now you're at stage C, and this is where the floodgates open in terms of medications that can potentially help you and devices that can potentially help you. And then stage D, these are the sickest patients, these are the advanced patients, these are the patients that we're really talking about things like something called inotropes, which I didn't go into today, but continuous IV medications that can help you feel better. And then sometimes we do refer patients for things like mechanical heart pumps or left ventricular assist devices or even heart transplantation. That's someone else's heart in place of yours. That's a small subset of heart failure, but there are a group of patients that are candidates for those, and we certainly help those patients, and we have a lot of experience pre-transplant and post-transplant at our prior institutions. And then I'm going to briefly mention clinical trials, and then we'll wrap up and take questions. Clinical trials are something I get very excited about. I have a pretty large background in research, and this is an area that I think is something that we should always pay attention to. Every single drug that I showed you today that has a signal of benefit where it can really help patients, every one of those drugs went through a clinical trial, right? Individuals with a disease said, I'm willing to be studied, and I'm willing many times to receive either a drug or to receive a placebo, which is a sugar pill or a drug that doesn't have the active ingredient. And in the form of the devices, many times we're doing studies where we're actually implanting something into your heart, or we have you go through a procedure and we don't implant the device in your heart, and then we study it. And we let science tell us, does this drug or does this device actually help you feel better or live longer? If we don't do the trials, we don't know. Right? Otherwise, we're just hoping that something works. And a lot of times in clinical medicine, just because something makes sense doesn't mean it actually helps patients until you study it. I mention that because at our program, we're participating in a good number of clinical trials. A trial that can, something where we can, it's called aquapheresis, where we can remove fluid in congested patients who are hospitalized. We have a couple of trials on the bottom left if you have a leaky mitral valve, where we can go in through the coronary sinus, which is the back door of the heart, and actually tighten that valve and see if it helps people. On the bottom right, we're actually putting tiny holes in hearts in 2 different clinical trials to see if we shunt blood from one side of the heart to the other side, can it help those specific patients do better? And then on the top right, we mentioned it earlier, these PA pressure monitors. Many times we'll put catheters in the lungs or in the pulmonary artery, we'll put pressure monitors there, and we're about to start a study where we're going to correlate the pressure monitors, pressure readings from the lungs to a marker on your arm and see if we can estimate what the pressures are in your lungs with a transducer on your arm. So we're doing a lot of cool stuff, and like I said, clinical trials, if they ever come up, I'd encourage you to at least consider them. May not be the right thing for you, maybe too time-consuming or cumbersome, but the only way we really make progress in all of these fields is when we work with our patients and we study these new ideas. And lastly, I'll leave you with a brief editorial. I've written about this, a lot of folks have written about this before me, this idea of the name, right, heart failure. It's a tough name to hear, it's a tough diagnosis to hear, and there's few people in this space that feel maybe failure is a strong word, right, because words matter, right, the connotation matters, how you feel about a new diagnosis matters, and not that it shouldn't receive the attention that it does, it certainly should, but many times, myself included, I will use other terms, things like advanced heart disease, for example. Serious, it's advanced, we're here to help you, but I try not to let the terminology dissuade patients, because for some people, the words can really bog a certain set of people down, and that's not what this is at all. As we've talked about tonight, there's so much we can actually do to manage this condition, and you can basically live a life like anyone else, so that maybe we don't need to call it failure for everybody. So wrapping up, heart failure and heart disease is largely preventable from the get-go. This is a common cause, particularly in elderly individuals being hospitalized, and a potential cause of a high risk of mortality. The diagnosis, Dr. Yoon covered this perfectly. We put all the clues together. This is talking to you. This is listening to you. This is hearing from you, what's been going on and what's really limiting you. This is a slew of tests, blood tests, imaging tests, sometimes procedures. We want to manage your risk factors to try to prevent this. If we make the diagnosis, I hope we've highlighted, we have so many tools to actually help you, medical treatments, device treatments, clinical trials. And then lastly, treatment, it's going to reflect all of that. There's so much we can do to help, and that's really the goal of tonight, to let you know about it. And lastly, like I said, what's in a name? Let's take the failure out of it, because we have so much we can do to help you guys. So thank you so much.
Wasn't that amazing? So really quick, this is our Q&A section. I'm gonna, if you don't mind, go around, and if you don't mind speaking in the microphone. And the reason is we have a number of guests who are on virtually, okay? So if you don't mind speaking in the microphone.
Not at all. Lipoprotein A, little, is there a study yet going on about that? And I was told that, well, you just have it and you could drop dead any day. You know, I mean, what do you do about that? I first had it tested in 2019. My numbers were 277, and now they're 216. Now, I don't know how I brought that down, but I don't know. I was told there wasn't any studies, and there was no treatment for it.
Sure. So I'll give my take. The question is about a biomarker, a cholesterol marker called lipoprotein A, or you'll hear people say LP little a. This is a marker that's been around for some time. It's received a lot more attention in the prevention space in the last 5 years or so. And the idea being it's a separate marker. It's a cholesterol marker, but it has a high genetic predisposition. My LPA is high as well, and I have a family history of heart disease, so it's something I pay attention to. From my perspective, the first line is, once you know it's high, it's still all about prevention, prevention, prevention. So I start my high LPA patients on statin, even if their LDL cholesterol is modest. That's number one. And then number two, there's 3 clinical trials that are ongoing right now for primary prevention, prevent heart attacks, secondary prevention, prevent another heart attack in people that have isolated high LPA. And these are mostly IV infusion therapies, and there's one oral therapy. They're being studied now. We'll have clinical trial results for at least one of them next year. But this is a marker that many of us are checking pretty often now, or at least more regularly, because I have a feeling we're on the precipice to have treatments for folks like yourself.
Thank you, Dr. Shah. Sir, you have a question.
Hello. Is atrial fibrillation curable or just manageable? And do you consider it to be heart failure as well as heart disease?
Yes, atrial fibrillation can be curable, but even, so there are a variety of techniques, procedures that a special type of cardiologist called an electrophysiologist can do for people with atrial fibrillation with very good success rates, 70% in some cases or even higher. Which means, unfortunately, that sometimes these procedures don't work, but for the majority of patients, these procedures can work. But even for those patients where the procedures do work in curing the atrial fibrillation, these cardiologists, electrophysiologists do recommend that patients continue to take their blood thinners every day, because there is, even if it works now, there's a chance for the atrial fibrillation to recur and come back someday in the future. And I apologize, I didn't catch your second question.
No, I just wondered whether you considered heart failure atrial fibrillation or just heart disease, or if there's the distinction between heart disease and heart failure.
Atrial fibrillation and heart failure are very highly correlated. They're separate diseases, but there's a significant amount of overlap. And certainly people with atrial fibrillation, it is a risk factor in causing heart failure. So that for many of my patients, when we cure the atrial fibrillation, the heart failure can actually disappear and go away.
Thank you. Yes.
Thank you. Dr. Yoon, you talked about catheterization and contrast dye.
Yes.
So what would be the contrast dye? And if you're allergic to it, what do you do in that situation?
Yes, there are a variety of methods that interventional cardiologists can use for people who are allergic to contrast dye, using a variety of medications, Benadryl, in some cases even prednisone, to reduce the risk of allergic reactions to contrast dye. Yes.
Next question over here.
Yes, why are there so few heart transplants relative to the number of heart-related deaths?
It's a great question. The question was, why is the number of heart transplants relatively stable, or the number of heart transplants happening year after year relatively stable? There's a kind of a long explanation for that. Number one, the number of suitable donors hasn't necessarily increased over time in the United States. As you know, here in this country, at least, when you go to the DMV, you choose to opt in or opt out as being an organ donor, right? And in many other countries, it's actually opt-in by default. And so the number of available individuals who have the capability of being an organ donor is higher in other countries. And in our country, the last few years, the number of transplants has been going up, but it's still a very small amount, unfortunately.
We have a question from one of our online guests. Is a lower protein diet suggested for amyloid protein conditions?
No, I don't.
Shall we flip a coin, gentlemen?
No, I don't think it makes a difference, no.
Oh, I'm sorry. Yeah, the question was, is a lower protein diet suggested for amyloid protein conditions?
Yeah, I think it's a fascinating question, but I don't think it makes a difference now.
This is about Dr. Yoon. There was 4 classes of the ejection factor, and 55 or higher is normal. Is there a specific number for each of those 4 classes?
You're talking about the 4 classes of the New York Heart Association, meaning class 1 being mild and class 4 being severe?
Dr. Yoon, do you mind repeating the question?
Okay, sure.
Thank you.
So the gentleman asked for the 4 classifications of the New York Heart Association scheme. Just in review, class 1 being very mild symptoms, class 4 being very severe symptoms. Is there an associated ejection fraction with each of those classifications from mild to severe? And the quick answer is no. This is one of the very fascinating things about heart failure, is that sometimes you could have a patient with a very low ejection fraction with very mild symptoms. And other patients, so for people with very severe HFpEF, that's heart failure with preserved ejection fraction, you can have a very normal ejection fraction of 60%, but they'll have class 4 symptoms. So ejection fraction, there is a strong correlation with symptoms. Don't get me wrong, but there's a lot of variance. There are some people who feel very good with low ejection fractions, and there are some people who feel terrible with normal ejection fractions.
Next question here.
Yes, can you explain a clinical trial, actually what that is, and where a patient is either given the placebo or the real thing, and why aren't they told, and a little bit of what goes on, like say a year's trial of?
Yeah, so that's a great question. The question was, what is a clinical trial and how is this issue of treatment versus a placebo navigated from the patient perspective. So as I mentioned earlier, all of the drugs that have been studied and many of the devices have to go through a clinical trial. Many of these, many in medicine consider the gold standard, the highest bar, a randomized, double-blinded clinical trial. What that means is you take a group of individuals, if we have 100 people here tonight, and we're going to study a new drug in that condition, we're going to randomize, which means half of the room will be randomly assigned to the drug. The other half is going to be assigned to a placebo. So it looks like the drug, but it doesn't actually do what the drug does. And I said double-blinded. Double-blinded means traditionally the participant and then the investigator. So in a clinical trial, it could be myself or Dr. Yoon. Many times we don't know if you're receiving the drug or you're receiving the placebo. There are people that know, there are study sponsors that know, there are other investigators that know, but the idea is we keep treating you the same. We treat you the best we can with everything else that we have. And then when the trial is completed, to your point, people are unblinded, so you learn, was I receiving a drug? Was I receiving a placebo? Did I have the hole in my heart? Did I not have the hole in my heart? Right? And then we look at the data long-term. Again, ideally, whatever the investigation is, did it help individuals feel better or live longer? Did that answer the question?
Yeah, I'm just wondering if the drug, you say you took the drug or not take the drug for a whole year of the trial, and then is it sometimes that this drug is take another year for it to work through your body to make you feel better, or that just depends?
It probably depends on what the drug is. The question was, if you're not receiving the drug, what are the implications for you? Many of these trials, if the investigational arm, meaning the people being studied for something new, if that's proven to be effective by the end of the trial, more often than not, the people that were in the other arm, which is the placebo arm, they're more often than not offered sort of first in line the drug or the device if it was shown to be beneficial.
We've got a question over here. Sorry.
Thank you. I have two different questions. Number one, you mentioned diet. You talked about the Mediterranean diet and the DASH diet. Is intermittent fasting good or bad for the heart? That's my first question. My second question is, I like to go hiking. So if I'm hiking somewhere remote, and then I have some sort of a symptom of a heart failure, what should I do?
So in regards to intermittent fasting, so the first part of his question was, is there any benefit to intermittent fasting? The second part of his question is, if he's out hiking or doing something and he starts to experience heart failure, what should he do? As far as intermittent fasting or other types of diets, I just want to say, do what's best for you. In regards to the diet, the Mediterranean diet, DASH diet, fantastic, wonderful, low salt. But if intermittent fasting works for you, then please go with it. I work with my patients to help them in whatever makes them feel happy and good, as long as it's healthy. As far as what you do when you go out hiking, one thing I tell all my patients all the time is that I really want them to be active. I want them on their feet. I want them to enjoy life as much as possible. And the formal recommendation for anyone with heart disease is to be on your feet walking at least 30 minutes a day, at least 5 days a week. But I'd like them to walk even more than that. So I'm a big fan and proponent of hiking. Now, if you're starting to feel significant symptoms of shortness of breath or chest pressure or chest pain while you're walking, certainly stop, seek medical attention. I think that's the appropriate thing to do.
Next question over here.
Hi, I have a question for Dr. Yoon and for Dr. Shah. For Dr. Shah, I want to know about insurance and the medications you were describing, like for obesity. Insurance is very challenging to cover those drugs, and is it going to change now that cardiology is going to have some input? Because I have a wonderful cardiology team. I had a quadruple bypass, and I haven't even thought about discussing this with them, even though I've gained the most weight I have ever gained in the last year, and my primary doctor, she just going by the diabetes. I'm not fat enough, she says. So I want to prevent that. My stamina is not to the point where I can work out all day long. So the question is, will insurance get more, what's the word? Would they get more flexible?
Sure. So
And then for Dr. Yoon, I have a question for him too about the BNP numbers that you said I didn't get an actual number of what's high and what's low, because I was recently diagnosed with congestive heart failure, but my cardiologist was really upset because I was diagnosed by someone who's only seen me once in an emergency situation. So, but I don't know what these BNP numbers are, like what's a good number and what's bad. So,
okay.
thank you.
So the first question was with respect to the obesity medications or the GLP-1 agonists, and the question has to do with insurance coverage. Generally speaking, you're completely correct. The more of these large randomized trials that are performed and published, and the data is out there, and now there's three technically in the heart failure preserved ejection fraction space, and I think we're going to start to see them in the reduced ejection fraction space. The more science that comes out, the more likely insurance companies are to cover that medication for this disease. You're correct that they many times will cover it for obesity, but you do often have to jump through a lot of hoops to have them covered for obesity management, and it can be tough. And I do believe right now some cardiologists are prescribing them, not all. I have a feeling that if the science keeps evolving the way it has been, I have a feeling 3 to 5 years from now, many cardiologists will be prescribing that class of medications because, as I mentioned, this idea of treating obesity as a separate disease is really becoming more in vogue.
I agree with everything Kevin said in regards to those medications. I think these medications are wonderful. I think they have such amazing benefit for the heart. I prescribe them for my patients quite frequently as well. And I understand that the insurance aspect of things is very, very challenging because I run into that quite often for my patients that I prescribe these medications to, how frequently things get denied. It's very frustrating for me, especially recognizing that a lot of these medications were originally over $1,000 a month. I think recently a number of them have been decreased down to $500 a month. But for whatever reason, that's just our country. If you go to Europe or Canada, these same exact medications, same exact doses are only $100 a month. So I think there is a groundswell of recognition of how beneficial and helpful these medications are in this country, that some of these prices are just a little too high for the majority of the patients to benefit from. And so I hope and I pray that with time that the prices will come down so that more patients could benefit from them and insurance companies will be more accommodating for that. In regards to your question for BNP, in general, the number is 100. If you have a BNP less than 100, it's considered normal. And if you have a BNP higher than 100, it's considered high. Now, just some caveats. There are things called false positives and false negatives. There are a number of other conditions which can cause a BNP level to go high, independent of heart failure. Same as well. BNP levels can be less than 100, and you could still have heart failure. It's called a false negative. And we tend to see that more in patients who are obese or larger for reasons we don't fully understand. Their heart, even though they're in heart failure, they can have a BNP that's artificially low.
We have a question from one of our online guests. How can you tell if shortness of breath is heart or lung related?
It's a good question. The question, if you didn't hear, is how can you tell if shortness of breath is heart or lung related? This is something that, we start off when we start our medical training, it's kind of early on, we're taught to keep broad differentials, meaning when a patient has a new symptom, the person asking the question is completely correct. It can be the heart, it can be the lung. There's a long list on the differential diagnosis for shortness of breath. As cardiologists, we tend to focus on the heart, so we do lots of investigations that Dr. Yoon covered today, the blood tests, the imaging, the x-rays, heart catheterizations. We use all those tools to ask ourselves, what's the likelihood that there's a heart condition causing shortness of breath? But that doesn't mean you may not have coexisting lung disease, for example. And that's a separate diagnostic cascade or pathway, X-rays, lung function tests, that can help you better understand how your lungs are doing. So unfortunately, a person's allowed to have two different diseases, and we often focus on the heart.
Okay, thank you.
Next question over here.
Yeah, hi. For someone with a paroxysmal AFib, with a CHA2DS2-VASc score of 3, but now in sinus, does she still need to be in a lifetime of blood thinner?
Short answer would be yes, yeah.
What was the
For someone with paroxysmal atrial fibrillation, so we've referred to atrial fibrillation quite frequently in this presentation. It's a rhythm abnormality that comes from the top two chambers of the heart, and it's fairly common in people as they get older. And the reason why we don't like atrial fibrillation is that when the top two chambers of the heart aren't contracting smoothly, but they're fibrillating, which means they kind of contract in a very unusual, wriggly type of motion, it makes it very, very easy for blood clots to form along the inner lining, the inner surface of that heart chamber, the top two heart chambers. And if those blood clots flick off, say they go to the brain or some other parts of the body, it can be catastrophic. For that reason, people with atrial fibrillation are recommended to take blood thinners for every day for the rest of their lives. So in general, for people who have atrial fibrillation, whether it's paroxysmal, meaning it comes and goes, or if it's persistent, meaning it's there all the time, your risk of having a stroke is about 8% per year. By taking a blood thinner, you decrease your risk of having a stroke from 8% per year down to about 2% per year. It's still possible to have a stroke, but the risk is much, much, much lower. And then you balance that out with the risk of bleeding, having a major bleed because you're on a blood thinner. You know, if you cut yourself while you're cooking, you're going to have to hold it a lot longer to make it stop bleeding, things like that. And in general, these blood thinners have a risk of major bleeding of about 0.5% per year, which is still really, really low. So the recommendation is yes, even if you have paroxysmal atrial fibrillation, but you're not in atrial fibrillation at the current time, you still have a considerable risk of it coming back in the future. And your CHA2DS2-VASc score is a way of risk stratifying what is your risk of having a stroke. CHA2DS2-VASc score of 3, as you mentioned, means a pretty decent risk of having a stroke. So yes, the answer would be to take a blood thinner every day for the rest of your life, unless at some point in the future the risk of bleeding exceeds your risk of having a stroke, in which case you and your doctor may have a discussion to stop the blood thinner.
Thank you. Sir, you have a question?
Hi, I have high cholesterol levels. My total cholesterol is 282, LDL is 202, HDL is 53, and triglycerides are 127. My doctor has prescribed me statins. I've been on rosuvastatin, simvastatin, like each time, and each statin causes extreme body pain. Like, it's like I have COVID, something like that. It's like extreme body pain, something which I've never experienced apart from when I had COVID. So now I'm on the third statin. I'm trying the third statin, which is pitavastatin, and I'm on 1 mg dose, and I'm taking it every day. But I'm having extreme body pain again with back pain. So I've been trying this since past 2 weeks. I don't know what to do now.
And we chatted about this before the talk a little bit. So the questions about statin intolerance or statin myalgias, many people may have heard about these or maybe you've experienced them yourselves. Some people, when they take statins, they may experience muscle aches, and then what to do about that if you experience muscle aches. You know, with those cholesterol numbers, as we kind of discussed before this, particularly in a South Asian individual, I'd certainly work to get you on some medication. I think there's two pathways. One is to throw in the towel with the statin and work with other medications. The ones that come to mind are the PCSK9 inhibitors. These are weekly or biweekly injections that also lower LDL pretty dramatically, and they're usually more well tolerated, and many times insurance will cover those. if you're truly statin intolerant, which it sounds like you are to some degree. That's one pathway. The other pathway that I've had some success with is a titration protocol, which means we take a very low dose of a statin, introduce it very slowly, once a week, 2 days per week, 3 days per week, and then I'll actually up titrate it over months. And many patients I've had success with who had muscle aches on medium to high doses basically start the whole thing over at a very low dose and kind of sneak it in the system. Many patients don't have the muscle aches if you bring it on gradually. That's what I would recommend, at least. I don't know if you have other thoughts.
The question is that I'll deal with muscle aches for like 3 months, 4 months, and then finally like will it go away after 3, 4 months, 5 months? If I keep on increasing the dose of statin?
So the muscle aches that are associated with statins, they're partially dose dependent if they happen, and usually if you stop the drug, they should go away pretty quickly if they're related to the drug, meaning you could also have muscle aches for another reason.
No, with statin, as in like if I keep on having the statin, will the muscle aches disappear with time? Like will my body get used to the statins over a period of 4 months, 5 months, or will it never get used to it?
Yeah, it's a good question. The question is, if you stay on the drug, will you eventually develop some tolerance, right, and not have it? Usually not. Most patients, if you have the muscle aches and they're tough enough, most people just stop the drug and the muscle aches go away. What I recommend is either different class of medications altogether or retry at a very low dose and see how you do.
Next
Yeah.
question here.
Hi, I have 2 questions. Is it possible to repair a leaky mitral valve? And if so, how is it done? A severe one.
Yes. So the mitral valve is the main heart valve between the left ventricle and the left atrium. And a severely leaking mitral valve can, over time, even in someone with a normal ejection fraction, cause a reduced ejection fraction. So in this type of a situation, there are a variety of techniques to fix the valve. You could either have surgery, so there are mitral valve repairs, and there are mitral valve replacements. Depending on the anatomy of the individual patient, sometimes the surgeon can repair the heart valve. Other times he finds out he can't repair it, he just has to replace it completely using an artificial heart valve. And we also have a new percutaneous technique called the mitral clip. In much the same way as the coronary angiogram, the cardiac catheterization that I showed you previously during my presentation, there's a way of using catheters going through the groin, of going up into the heart, to fix the mitral valve by placing a small clip there to reduce the amount of leaking. So short answer to your question is yes, there's a variety of ways, surgical and non-surgical, to fix a leaking mitral valve.
Next question here.
Hello, I had breast tenderness for spironolactone. Inspir was given about a month later. Still experienced it. Is there another drug in that class?
So the question was, you were prescribed spironolactone and then eplerenone, and you had breast tenderness as side effects with both of the medications. Right. And those are the two, go ahead.
The Inspir was given about a month later, so I don't, perhaps it carried over from the spironolactone, I don't know. But I heard someplace that there was a clinical trial for a third drug, but I checked Dr. Google, and there was firenone.
Yeah.
Is that in the same class?
It is. So a common side effect for this class of medications, which are mineralocorticoid antagonists, traditionally spironolactone has this side effect more often than eplerenone, the side effect being breast tenderness or gynecomastia. There's a new kid on the block called finerenone, which is a non-steroidal mineralocorticoid antagonist that's been studied compared to placebo, has very positive benefit for patients potentially like yourself. And the side effect profile has been pretty promising in terms of gynecomastia. So there is an option for you, which is finerenone. Thank you. Yeah. The newer version, or a different version, spironolactone, eplerenone, and the last one was finerenone with an F. I could spell it, yeah. Finerenone, finerenone. Just one, finerenone.
Okay, you guys, it is 7 o'clock, so we're going to cut it. Both Dr. Yoon and Dr. Shah are more than willing to stay after and answer any additional questions. We also have 2 members of our team who are in the lobby who are more than happy to take your blood pressure if you're interested in that as well. Also want to let you know that afterwards, about a week after tonight, you will receive a link to this presentation on YouTube. You'll also receive a PDF of the presentation that Dr. Yoon and Dr. Shah gave us this evening. And I think we'll include a PDF of the article, the op-ed that you shared with us, Dr. Shah. So please join me in thanking both Dr. Shah and Dr. Yoon. And share your feedback. If we don't hear from you, we don't know what to build upon and or to modify, and we want to know what topics are of interest to you. So please let us know.